Good morning, all. So I welcome you all to the session of INI-CET Hackathon. So really, this session is going to be an hacking session where we will hack the methodologies to INI-CET, and also we'll hack the pattern of questions to INI-CET. So when compared to your NEET exam, INI-CET is one exam where you can predict the pattern of questions. So here the topics which are quintessential are going to be repeated year after year, and you can see a particular pattern of questions being asked in the NEET exam. Rather in INI-CET, you can see the questions are exact repeats of previous year questions or pattern of questions, and the topics will be similar in years together. So how to go about with your preparation? So when we consider your preparation, I personally feel if you make your small steps properly, you can reach the sky, whereas when you have an improper schedule or an improper pattern of learning, then reaching the goal or success is going to be difficult. So I ask all of you to plan your pattern of reading and pattern of preparation of different subjects. So if there is no pattern or no proper scheduling, then it's going to be tough for you people to reach each small step in a proper manner. Rather, you will be aiming high, but the steps will be very long to reach, and you will not be able to even reach half mark of your goal. So this is very important in your INI-CET preparation. So second thing is always have your goals. Okay, set them goals, micromanage your goals, and you be at them. You be ready for your goals, and you will reach them definitely. Okay, so what difference your INI-CET preparation makes? So you can tell me, I have got a good rank in my NEET-PG exam. I'm happy with that. But if you are going for an INI-CET preparation in a proper manner until your NEET counseling happens, then what happens here is you will be reaching a place where all the modern amenities of investigation and treatment part will be available, and this small goals all through the day till your INI-CET is going to reach you places where you're going to be one of the topmost physician or surgeon in the country. So with this, what I feel important in medicine is these are most asked questions in recent years in your INI-CET exam. So the first and foremost is acid-base balance. So you should be very thorough about acid-base balance and electrolyte imbalance. These should be the most important topic which you are going to study. Okay. So second one is endocrine is very important. Okay, in recent years, if you see the pattern of questions, endocrinology is given much important, and the third one is cardio. Okay, and the fourth one is hemat, which is being covered in pathology. So you have definitely one question is going to come from pathology. Then rheumatology. If you take NEET, the amount of questions asked in rheumatology is little less. Okay, but rather here in INI-CET, the rheumatology questions are having an upper hand, and it is easily scoreable also. The third, the last one is going to be your neurology. So if you take neurology is again one important topic, considered to be one of the tough topic. But if you see INI-CET, the pattern of questions is again predictable and it is easily scoreable. So I have made this as SRK sessions. Okay, SRK sessions is Shivaraman's key session on important topics. So if I am going to go, I will be sharing the important topics to you. If I'm going to go with neurology, so I'm going to start with the neurology, and I will be talking on neurology and respiratory medicine today. Okay, and we will have 3 sessions. Over the period of 3 sessions, we will be covering all the important topics necessary for the exams. Okay, so now I will directly start with your next topic. Okay. Okay. So I'll be starting with neurology. So neurology, as I told you, is going to be INI-CET very well. So the first topic is going to be neurology. Okay. So in neurology, the first part, what we are going to discuss is stroke. Stroke. So ischemic stroke, hemorrhagic stroke. Yes, you know that, right? So 85% of cases are going to be ischemic stroke, 15% of cases are going to be hemorrhagic stroke. Okay, if you take ischemic stroke, thrombotic stroke, and the next stroke which we are going to be considering here is going to be your embolic stroke. Okay, so out of this, the embolic stroke is the most common stroke. Okay, and this thrombotic stroke can be further divided into large vessel stroke, small vessel stroke. So large vessel stroke is going to involve a large artery, and it is going to be like your MCA territory, which is most commonly involved. Okay, so it is the middle cerebral artery territory is the most common involved area. Whereas if you take the small vessel stroke, it is going to be lacunar infarct. It is going to be the perforating arteries or perforating branches of MCA territory. Okay. So this is very, very important to know. Coming to embolic stroke, an embolic can form from an artery to another artery, and the most common cause is going to be from the source is from the bifurcation of carotid artery. Okay, and coming to the next cause is going to be cardioembolic stroke, which is going to be the most important causes non-rheumatic AF. So if you consider this hemorrhagic stroke is again very important. Okay, so if I'm going to ask you what is the pattern of presentation, so many times the patient will have a high BP, patient will be unconscious at presentation. Okay, mostly. Okay, and if you going to take the stroke, it can be a intracerebral hemorrhage, or it can be a intraventricular hemorrhage. So intracerebral hemorrhage or intraventricular hemorrhage. And coming to the next thing, which is going to be extracerebral hemorrhage. So you have the 3 layers of meninges here. Okay, so what you have is you have a subdural hemorrhage, extradural hemorrhage, and you have a subarachnoid hemorrhage. Subarachnoid hemorrhage. So it is extradural hemorrhage, subdural hemorrhage, and subarachnoid hemorrhage. So here, if you take the extradural hemorrhage is going to have a period called lucid interval. Lucid interval. If you take the subarachnoid hemorrhage, you're going to have a pattern here which looks like a star, and this is called as star of death appearance. Star of death appearance. Okay, star of death appearance. This is very, very important to note here. Okay, now coming to a patient with ischemic stroke. Before developing into ischemic stroke, he will have multiple episodes of stroke-like thing, which is going to be called as TAA, which is going to be mini strokes. Okay, so whenever you have a mini stroke, you have to think about a score called ABCD2 score. Here, A for age of the patient more than 60 years. Second, B, blood pressure more than 140 by 90 millimeter of mercury. C has two components, clinical features in the form of unilateral weakness. Unilateral weakness. Or the patient is going to have speech abnormalities. Okay, speech abnormalities. Then the next one is D. D is duration of weakness, whether it is more than 60 minutes, 10 to 60 minutes, or patient has diabetes. Okay, so these are the important things. And here, if you take the unilateral weakness, this has a score of 2. Okay, and duration of weakness more than 60 minutes has a score of 2. Otherwise, all the other things have a score of 1. Okay, 1. So why this is important? Whenever a patient has a score between 0 to 3, he has low risk for stroke. Okay, whenever the score is between 4 to 5, then it is moderate risk, and whenever the score is more than 6, then he is having high risk for stroke in future. So whenever a patient comes to you, whenever a patient comes to you with ischemic stroke, what you're going to do is the investigation of choice as such. The investigation of choice is going to be diffusion weighted MRI. But what we tend to do is we go for a NCCT, which will be readily available in most part of our country. Okay, so whenever you do a NCCT, the first thing what you get to see is you get to see a sign called hyperdense MCA sign. Hyperdense MCA sign. Okay, this is the first thing you will get to see. Followed by you get insular ribbon sign, which is going to be a loss of gray matter, white matter differentiation. And the third thing what you're going to get to see is you're going to see an hypodense lesion. So hypodense lesion. Okay, so these things you get to see in this patient. The first thing is you get to see a hyperdense MCA sign. Okay, followed by you're going to get a insular ribbon sign, and followed by you're going to get a hypodense lesion. Okay, so this is what you get to see in a non-contrast CT, and you all know that you're going to treat the patient for your ischemic stroke. So whenever you plan for treatment for ischemic stroke, okay, what happens is you should have your blood pressure controlled or not. That is going to be one biggest thing you're going to ask yourself, and that is what examiners also going to ask you also again. So here, whenever a patient is going to be put on treatment for increased blood pressure during an acute event of stroke. Okay, whenever you plan for IV thrombolysis, whenever you're going to plan for IV thrombolysis, then what you're going to do is you're going to keep your BP less than 185 by 110 millimeter of mercury. Okay, whenever you're going to plan for thrombectomy, then also you're going to keep your BP less than 185 by 110 millimeter of mercury. Okay, rather you're not going to plan for neither of the two. Okay, you're not going to go for thrombectomy. You're not going to plan for IV thrombolysis. You're not going to plan for neither of the two, but patient BP is high. Okay, then you're going to reduce BP and keep it less than 220 by 120 millimeter of mercury. So these are the targets, okay, which has to be reached. Okay, so the goal of BP control in patients with acute stroke, whenever you are planning for IV thrombolysis, keep it less than 185 by 110 millimeter of mercury. Whenever you are planning for thrombectomy, keep it less than 185 by 110 millimeter of mercury. Whenever you are not planning for any procedure, but BP is still high, and if it is more than 220 by 120, then it is you tend to keep the BP less than that. Okay, so that is very important to note here. So this is one important prime area for your exam. Okay, prime area for exam. So this is very important. Okay, so whenever you have a patient planned for treatment of stroke and he comes to you less than 4.5 hours, which is called as window period or golden hour, during that time you're going to plan for thrombolysis. Okay. So when you plan for thrombolysis, what is the drug you're going to use? You're going to go for tissue plasminogen activator, and usually it is going to be an ADrPLEXUS. Okay, ADrPLEXUS. So what are the indications for recombinant tissue plasminogen activator? It is going to be clinical feature is going to be evident of stroke. Clinical feature is going to be evident of stroke. Okay, then CT scan shows more than 1/3 of MCA territory. More than 1/3 of MCA territory. Then next is age of the patient, more than 18 years. Okay, time from onset of symptoms to administration of drug, less than 4.5 hours, which we have already discussed. Okay, so this you have to be looking into before planning for thrombolysis. Okay, thrombolysis. So this is very important. Okay, now whenever you have a patient, okay, and that patient comes to you after 4.5 hours and less than 6 hours. Okay, 6 hours. So what you're going to do is sometimes even few books says up to 24 hours. Okay, the next step is you're going to go for a cerebral angiogram. Okay, when you see the deficit is much more higher than the infarct size. Okay, and you also see a large vessel obstruction. large vessel obstruction. Okay, if it is going to be present, then you're going to go for mechanical thrombectomy. So you're going to go for mechanical thrombectomy. Whenever it is not so, then you're going to treat conservatively with aspirin. Okay, aspirin. And whenever it is more than 24 hours, patient presents to you after 24 hours, then also you're going to go for aspirin. Then also you're going to go for aspirin. Okay, hope I'm clear here. Okay, so if you have any doubt, you can let me at the end of the session also. But this is very, very important to note here. Okay, this is very, very important to note here. Okay, so this is how you will approach a patient with stroke. Okay, approach a patient with stroke. Okay, so you can go for mechanical thrombectomy. Okay, within 6 hours. Okay, 6 hours. And some books says you can maximum up to 24 hours you can plan for it, but not after that. Okay, after that you're going to go for only conservative treatment with aspirin. Conservative treatment with aspirin. Okay, now a patient is coming to you with a triad. Okay, what is the triad he is coming to you? Okay, whenever a patient comes to you with thunderclap headache, so they're going to tell you this is the worst headache of my life, sir. Okay, then the patient has very minimal focal neurological deficit, but has neck rigidity, okay, or meningismus like sign. Then you have to think about subarachnoid hemorrhage. Then you have to think about subarachnoid hemorrhage. Okay, subarachnoid hemorrhage. Okay, so subarachnoid hemorrhage, it is most common at anti-communicating artery, anterior artery junction. Okay, and it is most common over there. And if you take any kind of berry aneurysm, okay, non-traumatic SAH is more common with berry aneurysm. Okay, and if you take the most common location of berry aneurysm, it is going to be more towards the anterior circulation, that is ACA junction. Okay, then a patient is going to have berry aneurysm very minimal as you go towards the posterior circulation, but the maximum chances of rupture is more common over the top of basilar artery. Okay, as you go towards the posterior circulation, then there is high chances of complications. Okay, over the posterior circulation. Okay, that you have to remember. Okay, so what prodromal symptoms a patient with berry aneurysm can develop? So a patient with berry aneurysm can have symptoms, the prodromal symptoms like bitemporal hemianopia. Bitemporal hemianopia, temporal throbbing pain. So one of the important cause for headache, okay, acute headache, temporal throbbing pain. Then retroorbital pain with third nerve palsy. Retroorbital pain with third nerve palsy. And sometimes patient can present with even occipital pain. Recurrent occipital pain can be there. So whenever you have a patient coming to you, any one of the prodrome symptoms, you don't miss subarachnoid hemorrhage. Okay, there is high chances of aneurysm, and from those aneurysm, there is high chances of patient getting rupture and then developing subarachnoid hemorrhage. So don't tend to miss this. Okay, so this is very, very important thing which I want to discuss to you. The next thing is I want to discuss on circle of Willis. Okay. So if you take circle of Willis is very, very important. And if this is going to be the circle, okay, then what is going to happen? You're going to have this one, where you have two vertebral arteries joined together to form basilar artery. Okay. And this is going to be your PCA. This is going to be your internal carotid artery. This is going to be your ACA. This one is anterior communicating artery. Here there is going to be posterior communicating artery. Okay. And here you're going to have your EMCA. Okay. From your vertebral artery, you're going to have anterior spinal artery, which is 1 in number. And you have here pica. Okay. And from basilar artery, you have 3 arteries coming out, which is going to be your SPA arteries. So it is going to be superior cerebellar artery, pontine artery and perforating branches of basilar artery, and anterior inferior cerebellar artery. So these are the arteries. Now, if I'm going to superimpose this with brain, okay, if I'm going to superimpose the brain like this, so if you take the medial part, it is going to be supplied by the ACA territory. If you're going to take the lateral part of the brain, it is going to be supplied by the MCA territory. If you take the posterior part, it is going to be supplied by the PCA. And coming to the brain stem, so this is going to be your brain stem. This is going to be your midbrain. This is going to be your pons, and this is going to be your medulla. Okay, I'm going to make a bigger picture of the smaller version here. There are 2 vertebral arteries which is going to join together to form basilar artery. Basilar artery is going to divide into 2 divisions, which is going to be a posterior cerebral artery. So any midbrain syndrome, then think about a posterior cerebral artery. Whenever you have anything related to your thalamus or subthalamus, for example, you have a syndrome which all of you know, that is going to be a Degenine-Rossi syndrome. Okay, where the patient will have hemianesthesia followed by excruciating pain. So there also, if you take, it is going to be your P1 segment of your PCA, which is going to be called as Percheron artery or thalamic geniculate artery, which is going to supply the subthalamus and thalamus, and the patient is going to have the syndrome. Okay, so now here we are going to have one anterior spinal artery. Here, pica. So if I'm going to divide this into 2 halves, this is medial part, which is supplied by your vertebral, anterior spinal artery, and this is going to be the lateral part, which is going to be supplied by the vertebral artery more than pica. So medial medullary syndrome, ASA, lateral medullary syndrome, vertebral artery more than pica. Okay, so this understanding is very, very important here. Okay, so hope you understood this thing. Okay, so this is very, very important point to note here. Okay, so make sure you understand this. Okay, so whenever you have a ACA territory getting involved, okay, so ACA territory involved, what are the clues in your questions which can give a lead to your answer? Okay, so if you're going to ask me what is a clue, okay, so mostly what you're going to see is the patient is going to have leg involvement more than arm involvement. This is the first clue you will get in the ACA territory. Second is the patient will be having antisocial behavior. Antisocial behavior. Okay. Then the third important thing which you are going to note down in your question is going to be the patient will have urinary incontinence, which is in inappropriate places. The patient is going to pass urine, and this is going to be your cortical bladder or uninhibited bladder. So that you are going to note down. Okay. Now coming to MCA territory. MCA territory. As I used to say every time, MCA is going to be a bigger one, which is going to give M1 segment, which further divides into two halves, superior division, inferior division. Okay, and the superior division is going to supply the inferior frontal gyrus, and the inferior division is going to supply the superior temporal gyrus. Okay, now this one is going to be your M2 segment. Okay, M2 segment. Whenever your superior segment of M2 is getting involved, what is going to happen? The patient is going to develop Broca's aphasia. Superior temporal gyrus is getting involved, Wernicke's aphasia. And whenever your M2 segment is getting involved, there is high chances patient can develop global aphasia. Global aphasia. Coming to M1 segment. M1 segment. M1 segment is going to supply internal capsule through lenticular branches. Straight branches. Okay. Then it is going to supply the basal ganglia. Okay. Whenever this part is getting involved, the patient is going to develop hemiparesis, hemianesthesia, homonymous hemianopia, and the cranial nerve fibers are going to pass through along the internal capsule in the genome, and it is going to have presentation as facial nerve palsy. Rather, coming to involvement of your basal ganglia, whenever basal ganglia is getting involved, the patient is going to develop Parkinson-like feature. Parkinson-like feature. Okay, so this is very, very important to note here. Okay, whenever you take your lateral surface of brain, the lateral surface of brain, you have here a part called angular gyrus. Angular gyrus. Whenever your angular gyrus is getting in dominant parietal lobe, it is dominant parietal lobe, the patient is going to develop a syndrome called Gerstmann syndrome. You're going to develop a syndrome called Gerstmann syndrome. Gerstmann syndrome. So what are the components of Gerstmann syndrome? Okay, if you take the Gerstmann syndrome, the components of Gerstmann syndrome are going to be very, very important. Okay, so there is again a controversy whether alexia to include here or not. Okay, but we will go conventionally. It is associated with acalculia, agraphia, right and left disorientation, finger agnosia. Finger agnosia. So these are the four parts. Okay. So this you all know this, but you have to remember it is going to be dominant parietal lobe. Okay. Since it's a revision class, I'm just touching on the important things. Okay, so we cannot explain the minute details or final details of these things here. But again, I'm going to tell you this dominant parietal lobe. Whenever you are going to have right and left disorientation. So what can be the distractor in your exam? That is a feature whenever your right or non-dominant parietal lobe is getting involved. The patient is going to develop a feature called hemi neglect. So what is this hemi neglect? So imagine this fellow who has infarct or a lesion over the non-dominant parietal lobe or right side. What he will do is, whenever he takes food, okay, he will take food only from right half. Okay, he's going to take the rice from here. Okay, he's going to take the rice from here. Okay, right from here, and he's going to take all the subsies from here. Okay, rather this area is going to be totally neglected by him. This area is totally neglected by him. Here nothing will be taken by him. Okay, so that is very, very important. Okay, so he will tend to eat from only right half, and this half is neglected. So this is going to be your hemi neglect. Okay, rather if you take your Gershman syndrome, that is going to be when you tell him to write when you tell him to write Pondy, so normal person will write like this, but what he will do is he will write like this. So this disorientation will be there, right and left disorientation will be there. Okay, so this is very, very important. Okay, very, very important. Then next important thing to discuss, PCA. Okay, so whenever you have your P1 segment involved, as I told you, there is going to be two things, which is thalamic degerine Rossi syndrome, and the second one is going to be midbrain syndromes. In midbrain syndromes, you are going to have the first one, Weber syndrome, which is going to be third nerve palsy plus contralateral hemiparesis. The next one is Claudy syndrome, third nerve palsy, plus the patient is going to have contralateral tremors and contralateral ataxia. Then Benedict's, a combination of Weber's and Claudy. Okay, Weber's and Claudy. Okay, then you have Northern Angle. Okay, whenever you have Northern Angle syndrome, okay, you're going to have third nerve palsy along with ataxia. And whenever the pineal gland is getting involved, pinealoma is there, then you're going to develop a syndrome called Parinot syndrome. So what you have to know in Parinot syndrome is, in Parinot syndrome, you will have upward gaze palsy. Upward gaze palsy. This you have to look for. So now, if there is a terminology called upward gaze palsy, then you're going to have downward gaze palsy. So where you're going to get downward gaze palsy? You're going to get downward gaze palsy in Steele-Richardson syndrome or progressive supranuclear palsy. So this is very, very important to note here. Next is, whenever your occipital lobe is getting involved, occipital lobe is getting involved. Due to involvement of P2 segment of your PCA territory, you are going to develop alexia, that is reading difficulty without agraphia. This is very, very important difference between your alexia with agraphia and Gershman syndrome, and here it is alexia without agraphia. Okay, so this is very, very important to note here. Okay, very, very important note here. Okay, so this you have to be very sure. Okay, because these are repeated things in your exam. Repeated things in your exam. Okay, these things are must know. Okay, must know. Okay, then the next thing is going to be, again, I want to talk about bilateral ventral pons involvement. Whenever bilaterally ventral pons is getting involved, okay, whenever bilaterally ventral pons is getting involved, what is going to happen is the patient is going to develop a syndrome called locked-in syndrome. Okay, locked-in syndrome. So here you are going to have spared reticular activating system. Okay, so if you take your pons, the pons has the areas for horizontal gaze. Okay, but vertical gaze areas are present in the midbrain. So what is going to happen is, if this is the patient who is coming to you with locked-in syndrome, okay, there will be bilateral facial nerve palsy. So what is going to happen? The patient is going to have no expression over the face or no sensation over the face. Then the patient is going to have bilateral weakness. Bilateral weakness. Okay, then there is no horizontal eye movement. Okay, there is no horizontal eye movement. The only movement possible in this patient is, this patient will be able to do vertical eye movements. Okay, and they will be alert and they will be listening to your speeches and all. So there's going to be, the patient is going to have, the only possible movement is vertical eye movements plus the patient will be alert. So this is called as locked-in syndrome. Okay, locked-in syndrome, very, very important. And here I want to tell about one more thing, Miller-Gubler syndrome in pons, Miller-Gubler syndrome, where you're going to have 7th nerve palsy, 6th nerve palsy, plus contralateral hemiparesis. Okay, versus Fovili syndrome. So Fovili syndrome is one where you're going to have facial nerve palsy plus, this is very, very important. Here it is horizontal gaze palsy. Horizontal gaze palsy. Okay, this is very, very important. Plus, you're going to have contralateral weakness, contralateral hemiparesis. But this is very, very important. Here it is 6th nerve palsy. So it is lateral gaze palsy, lateral rectus palsy. Because of that, in that particular muscle, the lateral movement is affected. But here it is horizontal gaze palsy. Both the eyes horizontal gaze will be affected. So this is a very, very important thing you have to note here. Okay, very, very important thing to note here. Okay, so hope I'm clear about these things. Okay, clear about these things. Then coming to medial medullary syndrome, okay, versus lateral medullary syndrome. Okay, so again, this is this is very, very important. Okay, very, very important. So if you take medial medullary syndrome is ipsilateral 12th nerve palsy, contralateral hemiparesis, contralateral loss of vibration, position, proprioception. Rather, if you take lateral medullary syndrome, it is going to be ipsilateral fifth nerve, ipsilateral taste, ipsilateral vertigo, ipsilateral ataxia, then ipsilateral honors. Okay, honors. Then ipsilateral triple D, dysphagia, dysphonia, dysarthria. Okay, and here these are all ipsilateral, and you're going to have contralateral loss of pain and temperature over body. Here it is going to be over face, pain and temperature. Here it is contralateral over the body. Okay, over the body. Okay, so this is very, very important to note here. Okay, to note here. And the next thing is going to be your so hope I am clear till now. Okay, hope I'm clear till now. Okay, so hope you are able to listen to me and I'm clear till now. Okay, so these are all very, very important things. Okay, high yielding things for your exam in neurology. Okay, so that is very, very important thing. Okay, then next is next what we can discuss is going to be your two things. Okay, two things, very, very important things. Okay, so what are the two things is there is something called decorticate rigidity versus decerebrate rigidity. Decerebrate rigidity. Okay, decerebrate rigidity. Okay, so this is again very, very important. Okay, so whenever you have your corticospinal tract always have check over few tracks. Okay, it is going to inhibit at the level of midbrain, pons, medulla. It is going to inhibit like this. Okay, how it is going to inhibit? Okay, so if you take your midbrain, in midbrain you have the rubrospinal tract. Rubrospinal tract. This rubrospinal tract is responsible for flexion of upper limb. Then you have the next tract, reticulospinal tract, and you have the tectospinal tract. Tectospinal tract. So if you consider these two tracts, these two tracts are responsible for extension of upper limb and lower limb. Whenever a patient has lesion above the level of midbrain, what is going to happen? This inhibition will be lost. Whenever this inhibition is lost, what is going to happen is the patient is going to become like this. Okay, so they will have towards the heart. Okay, towards the heart, and this is going to be decorticate rigidity. Okay, cor means heart. Okay, so this is towards the heart. Okay, so decorticate. So you are going to remember decorticate. Okay, whereas when the lesion is below the midbrain, okay, whenever there is a lesion below the midbrain, what is going to happen? this tract is getting inhibited. This tract is going to become null, okay, because it is still under the inhibition of corticospinal tract. So only one thing which is going to have upper hand is your reticulospinal tract and your tectospinal tract. So what is going to happen? The patient is going to become like this. Okay, the patient is going to have like this. Okay, so this is going to be your, this is going to be, this is going to be your D cerebrat. Okay, this is D cerebrat. Hello. D cerebrat. Okay, so this is very, very important to note. Okay, so this is, hello. Okay. N3 na எந்த patient is it? Okay, எவ்வளவு இருக்கு? 223 ஆ? 233. நேத்து 24 கொடுத்தீங்களா? எவ்வளவு கொடுத்தீங்க? Okay. Okay, 20 units, இது 30 units actrapid, 20 units monotard. ஆமா. ஓகே, நேற்று நைட் எவ்வளோ கொடுத்துருக்காங்க? இப்போ 22 + 10. So sorry, so this is very, very important. Okay, this is very, very important to note here. Okay, this is very, very important. You have to note here. Okay, then next important thing which I feel important to know is your cord is like this. Okay, and this is the center of the cord. Okay, now you have crossing fibers here. The crossing fibers are fibers of spinothalamic tract, okay, which carries the pain and temperature. Now you have a condition where there is a fluids filled space, which is going to expand anteriorly, and the most common location is C8T1. Okay, when it happens like this, whenever this fluid filled space moves anteriorly, what is going to happen is the patient is going to develop loss of pain and temperature over the area which is supplied by C8 and T1, and this person is going to be having loss of pain and temperature over this part. Okay, if you consider this fellow is going to have loss of pain and temperature over the upper limb, and but VIP sensation, that is vibration, position, proprioception, is intact, and this is going to be called as dissociative anesthesia. And this is also called as cape distribution. Okay, and this condition, this is called as a syrinx filled space, so it is called as syringomyelia. Syrinx is a fluid filled space which compresses the spinal cord, syringomyelia. Okay, syringomyelia. Okay, then next important thing I want to discuss in the spinal cord is going to be this one. Okay, if you take the spinal cord like this, this is going to be your, so this is going to be your central area with gray matter, white matter differentiation. Here you're going to have your posterior column. Here you're going to have corticospinal tract, spinothalamic tract. Now what happens? A patient develops hemisection of cord. Okay, he develops hemisection of cord. Hemisection of cord. Whenever he develops hemisection of cord, what happens is this part of the cord is getting involved. Okay, this part of the cord is getting involved. Whenever this part of the cord is getting involved, for example, this fellow is having left-sided involvement. Okay, left-sided involvement. Okay, so this is a pictorial representation of your track. Okay, these two are ascending track. This is a descending track. For that reason, I have put like this. Okay, so now imagine this guy. Is having left side lesion. Okay, so if you take this guy is having a lesion somewhere here. Okay, lesion somewhere here. So what is going to happen? This guy is going to have loss of VAP over vibration, position, proprioception over ipsilateral side, loss of power or hemiparesis is there in the ipsilateral side. Okay, and this fellow is going to have loss of pain and temperature over contralateral side. Loss of pain, temperature over contralateral side. Okay, over contralateral side. So this is again very, very important here. Okay, so this is going to be loss of VAP over ipsilateral side, loss of power over ipsilateral side. Okay, and there is going to be loss of pain and temperature over contralateral side. Very, very important. Okay, so these are high yield areas in your spinal cord. So I thought I will discuss these things. Okay, these things, very, very important thing. Next is coming to the headache, migraine. Whenever you have any patient coming to you with a migraine, okay, so you have a classical migraine and a common migraine with aura, without aura. Okay, so here, whenever a patient has migraine, okay, the first thing is you are going to have a pulsatile head, unilateral headache, moderate to severe intensity associated with nausea and vomiting. Yeah, so there is nausea and vomiting. Okay, and whenever you have nausea or vomiting, so aggravated by movements actually, nausea and vomiting is present, or photophobia or phonophobia is present. So out of these four things, two things should be present, and out of these two things, one should be present. Okay, so this is very, very important. And whenever this patient is coming to you, okay, the headache will last for 4 hours to 72 hours. 4 hours to 72 hours. That is very, very important. So you have a treatment part here and you have a prophylaxis part. Treatment part is with your analgesics you will give. If it is not working, you will go for triptans, which is going to be 5-HT1-BD agonist. And next thing, it is not working, then you can also go for ergotamine derivatives also. Okay, ergotamine derivatives also. Okay, so this is very, very important to note here. Okay, so this is very, very important, and there will be an aura. And the latest theory says that it is due to calcitonin gene related peptide. Okay, and it is also due to a theory called cortical spreading depression. Okay, here the headache is going to be a pulsatile headache. That is very, very important. Okay, pulsatile headache. Okay, that is very, very important. Okay, pulsatile headache. Rather, another patient is going to come to you with this is the patient coming to you, and this fellow is having a pain which is retroorbital. Okay, retroorbital. The patient pain is retroorbital. The first thing what you're going to look here is whether it is male greater than female or male equal to female. Okay, whenever it is male greater than female, then you have to think about cluster headache. Whereas this male equal to female, okay, then it is going to be more towards paroxysmal hemicrania and sunk. Okay, then next important thing here is these pains are going to be throbbing type of pain. Throbbing pain will be there. Okay, or stabbing pain will be there. Okay, so if you take cluster headache, okay, the each attack, okay, cluster headache, each attack will last for 3 hours. Okay, 3 hours. So in a single day, a patient can get 8 attacks. Okay, 8 attacks. Rather, in paroxysmal hemicrania, each attack will last for around 30 minutes. So in a single day, a patient can develop around 20 attacks. In sunk, each attack will last for around 300 seconds. So in a single day, a patient can develop 200 attacks. So you remember this, like 3 hours, 30 minutes, 300 seconds. 330, 300. Okay, hours, minutes, seconds. Okay, this is very, very important. Even the book says that somewhere around 100 seconds the pain will last, but you remember like this: 330, 300. Okay, 330. And this paroxysmal hemicrania is also called as most commonly indomethacin responsive headache. Indomethacin responsive headache. So in prophylaxis, you can use indomethacin. Indomethacin responsive headache. Okay, this is very, very, very important. And if you take cluster headache treatment wise, you're going to go for oxygen. Okay, it is given at around 10 to 15 liters per minute. Okay, then you can go for triptans, sumatriptan. And if you take prophylaxis, you can go for verapamil. That is very, very important to note. It is very, very important here. And in one more important thing in cluster headache is here, alcohol acts as a trigger. Okay, that is very, very important to know here. Okay, so hope I'm clear till now. Okay, you have any doubt, you can let me know at any point of time. Okay, so someone is asking RST is reticulose. This is ruberospinal tract. This is rubrospinal, reticulospinal, this is tectospinal. Yes. Okay. So this is very, very important to note here. Okay. So hope we are clear till now. Okay. We are clear till now. And so with this, the headache part is also very, very important part. Okay. So we are trying to do this headache part, because headache part is again one frequently asked question in recent times. Okay. Recent times. Okay. So one more thing here, one frequent, again, last 2 years back, it was again a frequent question. So if you take your 10 rupee note, you have a face here. For example, you take an American dollar, okay, $10, 10 USD dollars, okay. So whenever you have a 10 USD dollar, okay, what you will see there, you will see you see 10 USD dollar, the person is able to recognize 10 US dollar, okay? Or also the patient is not able to recognize the face here, okay? For example, the patient here, the picture of George Washington is there, okay? And you being a person who settled down in America, and every time you get to see the 1 US dollars and 10 US dollars, and for example, 1 US dollar, you are not able to recognize the George Washington face, okay? Then this is called as prosopagnosia. Okay, prosopagnosia, where the lesion is at the junction of temporo-occipital lobe. Okay, this is called as prosopagnosia. Okay, this is one frequently again repeated question in your INI-CET exam. Okay, repeated question in your INI-CET exam. Okay, so this is very important. Okay, next is coming to seizures. Seizures, it's a very big topic, but you know, you are going to divide the seizures into focal seizures, generalized seizures. In focal seizures, I want to tell about whether it is a dyscognitive, non-dyscognitive. So when we come to dyscognitive seizure, okay, dyscognitive seizure, very important thing is the patient is going to have aura followed by focal seizures, followed by patient, along with seizures, patient can have two things. One is called stereotypic movement. They will do repeated movements, okay? And automatism. Automatism means they will have an abnormal movement like lip smacking. They will do like this. They will do like this. Like this, okay, that is called automatism, okay, and followed by patient is going to have amnesia, which is antegrade amnesia, and they also have post-ictal confusion. So these things will be seen in dyscognitive seizure, and these things are not seen in non-dyscognitive seizure. This is very important. I want to say here, and if it is going to be a GTCS, generalized seizure, in generalized seizure you have absence seizure. Then absence seizure, what you get to see is you get to see like this. This is called 3 heads spike wave pattern. Spike wave pattern, 3 head spike wave pattern. Okay. Then in pregnancy, the female is pregnant, is coming to you. Okay. And this pregnant female, what anti-epileptic drug you're going to go for? You can go for lamotrigine, which is proven. Okay, oxcarbazepine, then levetiracetam.